It's 4. Yeah, yeah. Okay. All right. I'm just going to start the webinar. Sylvia, if you could just wait for 15-20 seconds, let people filter in, and then you can start talking. Sounds good? Okay. All right. All the best.
Thank you. Same to you.
Lumna, can you make me the co-host so that I can handle the spotlighting?
Hi, and welcome everyone to this 10th National Bioethics Conference. And today's session, we have some very interesting speakers. And the topic of the session is Health Digitization in India, Voices from the Grassroots and Policy Spaces. And we have, I'm one of the co-chairs, and we also have with us Dr. Hamad Durrani. Dr. Hamad and I, we've kind of known each other for quite a long time, and we started off with a project with about 16 researchers from 10 Asian countries when we were just hearing about this whole concept. And that time it was called the Pan-Asian Collaboration for Evidence-Based E-Health Adoption and Application. And we had tried different things. We had tried mobile health. We had tried telehealth. A lot of sharing happened between the countries. And now Hamad is, he's very much focused on digital health, and he uses it in the space of health systems, and also to improve healthcare outcomes, especially in low and middle income countries. And he has published a lot extensively on digital health, and also a reviewer in a lot of peer review journals, specifically on digital health. So yeah, over to you, Hamad.
Thank you so much, Sylvia. Yes, we do go a long time back. So welcome everybody to this session. Our theme of today's session is artificial intelligence in healthcare, ethics, law, and human rights matters. My co-chair Sylvia is a public health doctor with 20 years of experience. She has worked on health and social determinants from rights perspective with communities. And she has worked with different organizations like Amnesty India International, People's Union for Civil Liberties, People's Health Movement, WHO, and during the COVID, she has also been involved in public health activities and relief work. We have 3 speakers today, and I welcome all the guests and all the speakers. We have Dr. Siddhi Rupa, we have Dr. Narendra Gupta, and we have Dr. Usha with us also. So if I can request Dr. Siddhi Rupa for her presentation. She is a research fellow and a program lead at Institute of Social Studies Trust in India, in New Delhi, where she leads the theme of informality, precarious work and care. Her research focuses on this intersection of labor precarity and care dynamics in various contexts, including the digitalization of work, paid and unpaid care work, and the circular economy. She has 15 years of experience, and her work spanned from care economy, informal labor, aging, healthcare, and migration. She's a PhD in economics from Center of Development Studies. And she's also a postdoctoral fellow from Center for Women Development Studies and King's College London. I welcome Dr. Sri Rupa. Please, the floor is yours.
Thank you so much. I'll just take a moment to put up my presentation. I hope this is visible.
Yes, it is.
So good afternoon, everybody, and thank you so much. It is such a privilege to be here amongst all of you for the 10th National Bioethics Conference. It's particularly a privilege, I feel, as a development economist working at the intersection of informal labor, care, and gender to be amongst all of you. So a special thank you to Sunita Sheel for inviting to share our work with all of you. I think before beginning my presentation and sharing this study with all of you, I just wanted to bring all of your attention to one of the recently published press release from the Ministry of Health and Family Welfares, which the title of From Data to Diagnosis, Transforming Healthcare Through Digitalization, published on January 20, 2025. So let me quote parts of it, which says that India's healthcare landscape is undergoing a digital transformation, driven by government initiatives, policy reforms, and technological advancements. With a rapidly growing population and increasing demand for quality healthcare, digital health solutions are playing a crucial role in enhancing accessibility, affordability, and efficiency. Digital healthcare infrastructure in India is evolving to bridge the gap between urban and rural healthcare services, leveraging telemedicine, electronic health records, and artificial intelligence. So the press release actually goes on to refer to a recent World Economic Forum article as well, and highlights that India has a potential to become a global leader in digital health by building a resilient digital health ecosystem. The report basically underscores the importance of a robust data governance framework and positions initiatives like the Ayushman Bharat Digital Mission as setting a global benchmark for digital public transformation. So clearly what we are seeing is that there is a rise of importance that's been given to digital public infrastructure in the public health governance space. And this has also been kind of supported by a lot of the global actors like WHO, which has supported this shift, and which is something which has been prominently highlighted during India's G20 presidency as well. So I just wanted to impress upon all of you the context within which this digital transformation is happening. And so what we need to understand is that, just a second. Yeah. So what we need to understand is basically this neoliberal ethic of data-driven governance within which all of this is happening, where data and technology is essentially seen as a silver bullet for all kind of development woes, including the public health woes, if I may say. And we know that AI heavily relies on data to learn and function. And in a public health governance framework where data and AI has been working very, very closely together, the focus remains on technology and governance, and somehow what gets overlooked is the human labor that is needed to sustain these systems. So at ISSD, when we were thinking about this study, and I'm basically sharing with you the recent study that we have published titled Digitalization at the Front Lines, the Asha's Experiences Across India. We were very keen, and we were, basically grappling with this core question that how is this rapid digitalization in the healthcare, which now recent scholars have also been calling platformization of governance, is transforming the lives of these frontline workers, particularly in this particular study, we are looking at the ASHA workers in the post-pandemic era. And as feminist scholars, I think we're asking ourselves that who really bears the burden of this digitalization and how these shifts, in fact, impact women workers like Ashas. whether it is really enabling them, is it increasing or enhancing their agency, or is it intensifying their vulnerabilities and precarities? And how they were even adapting to it collectively was something that was of interest to us. So in this particular study, we were very keen, given the power equations that are involved, that we adopt a worker-centric and a bottom-up approach to basically amplify the voices and lived experiences of ashas and their collectives, who get often marginalized in technology-centric, discourses and narratives. We adopted also very consciously a feminist intersectional approach, knowing that these workers are not a homogeneous group and there are intersectional identities which shape their experiences, whether based on caste, class, religion, age, education, or geography. The methodology that we adopted for our study, and in fact, the study basically started with a very rigorous scoping study, which we carried out in Haryana, because Haryana at that particular time was getting, in fact, the ashas in Haryana were getting a lot of attention due to the protests that were going on by the Asha Workers Union, wherein they were resisting what they believed to be a surveillance-based app, which was kind of imposed upon them, which they were asked to download on the smartphones which were provided to them by the state government, which they believe could track them and could see where they were moving and could also see the data that was put up on their smartphones. They collectively resisted and successfully managed to push back. And the state had to take back that particular app. So this is the context within which we had started the study. But when we conducted the study in Haryana, which is a relatively smaller state in India, we realized that there is so much of diversity in the experience of digitalization and its impact, even in a small state like Haryana. And if we were to say anything meaningful for a vastly diverse state country like India, we had to look at some of the other states, and we extended our study to 3 other states, namely Kerala, Rajasthan, and Meghalaya, to get some kind of a regional representation. And we adopted a multi-method qualitative research, intensive fieldwork involving in-depth interviews, FGDs, participatory activity mapping, and workshops with ashas and consultations with union leaders and other health officials. So I'm showing this particular slide to give you a sense of the array of apps or the flurry of apps which these ASHA workers have to kind of negotiate or manage. These are some of the apps that the ASHA workers in Haryana use on a day-to-day basis. A lot of these apps are basically apps used to collect data, digital data collection. Or digital surveys are done through these apps. Some of the other apps are used for like their digital payment. WhatsApp is a very important, has become a very important medium of communication for ashas across India. And some of the other apps are for meetings and for, training purposes. So through our study of these 4 different states, one of the important things that we realized is that there is actually no one form of way of digitalization that's happening. There is a spectrum of digitalization and wide variety of experiences of digitalization. So I'll take you one by one through these 4 cases that we had picked up. So what we found in Haryana was a very strongly a top-down form of a digitalization, very intensive form of digitalization. As I just showed you, the flurry of apps that they have to use, a very rapid pace of digitalization, which many times the workers found to be very extractive. An interesting quotation I've included here in the slide is something which was told to the ashas during a training review process, where they were nudged to become, smart ashas and pick up more digital skills and to use their smartphones much more effectively so that good quality data could be collected. But in this, in this push for digitalization and better data, what we found was that the workers had to bear the burden of increased work, because many times they were continuing to collect data using the paper format. And in addition, they had to do the digital data entry as well. And I did refer to the heightened surveillance due to some of the apps that were imposed on them, which the Asha Workers Union, successfully managed to resist. So on the whole, if you look at Haryana, we found that the Asha workers were becoming conduits to this digital data governance, framing of the state, and which also affected them in how their work was getting imagined and valued. And much of the time, they expressed that they were feeling alienated, and the Ashas were not really, there was a lot of resistance when we spoke to them about the digitalization of the work. To contrast Haryana, I will now present to you the case of Meghalaya, which, due to a number of, geographic and infrastructural challenges of very poor connectivity, extremely low levels of literacy. So one has to remember, even in the case of Ashas across India, this is a cadre of workers who are only expected to be 8th and 10th class pass initially when they were brought into this work, in 2005. But in areas where there is even poorer levels of education and literacy, like for example in Meghalaya, we've seen that some of the Ashas were not even, 6th class pass, so would be just 4th, 5th class pass. So there was very low levels of literacy and of course extremely low levels of digital literacy. And the skilling interventions of the state were not enough given the context. And so what we saw there was a much more nascent and a fragmented form of digitalization. And even the senior officials were much cognizant of the local challenges and had adopted a slow-paced digitalization, although they were very keen to transform to a digital public healthcare system. So in contrast, we also found cases, particularly like in Rajasthan, which has been a pioneer, so to speak, in digitalization and also has seen extensive digitalization of Asha's work, that the digitalization can also be worker-centric or worker-friendly. And what does that do? So one of the game changers in Rajasthan was the PCTS app, which allows the Ashas to access their collected data, track their work schedules, and identify opportunities for higher earning. So what this access to the data really allowed is that it allowed for the workers to have more trust and respect within the community, because they knew very well when an immunization program was coming and when the community members could get the money for timely immunization. So we found that the Ashas in Rajasthan were enthusiastically adopting and were becoming active participants, particularly with the onset of the PCTS app for the Asha workers. And so they didn't see themselves as just, data collectors, but as somebody who were, participants within this particular system and did feel valued, as you will notice in this quotation of Asha worker that I've put up on this slide. So here she says about how we get to know about the due date of the vaccination of people, and then we call them to get their vaccination done. This has made our work so easy, and this is the benefit of the existence of an online app. The other interesting case was the Kerala, was what was happening in Kerala, where we found that the digitalization process was much more slow and intentional in pace, with only really one major data collection app, which is the Shelly app for NCD survey, which was being implemented by the state. But what was really important in Kerala's case, I think, is also based on the much more decentralized participatory form of governance that's, is the ethos of the state, is that there was a robust digital skilling ecosystem, which was already there in Kerala with Akshaya centers, which allowed a lot of workers to have had exposure and skilled in computer skills as well as digital skills beforehand. And this was a game changer. Particularly, we found that the older Ashas who were struggling in other parts of in other parts of the country, in other states which we had studied, were much more able to kind of transition to digital work in Kerala. And the other unique thing was that there was collaborative processes, although at a nascent stage, in which the app designers were coming together with the ASHA coordinators in regular review meetings, where the ASHA coordinators could kind of give feedback on how the apps needs to be designed. So, just to sum up the experiences of ASHAs and what are the opportunities and challenges that we can understand from here, I think one of the key takeaways for us was there was this reimagining of a frontline community health worker, because now they were being reimagined as a technology worker, where they were being asked to transform into, smart ashas who are professional, savvy, digital data agents for the state. The other big thing was, the digital exclusion, which was so on our face. We realized that, rural ashas, older ashas, those who were illiterate, particularly those who belong to marginalized communities, Dalit ashas really found that the digital divide was increasing for them. Those with low levels of digital literacy and skills were the ones who were kind of losing out. And there were instances where ashas had, and even, some of the mid-level health officials had confided to us that in an attempt to meet the training targets for, these programs, what they would do is they would select the younger, more literate ashas to come and participate in these training programs, whereas the older and the less digital savvy ashas would be in a way excluded from these processes. So certainly there is an inadequacy in the digital skilling program that is there currently, and the ones that are there are also sometimes ineffective because the mode of transaction of these skilling programs. The other key takeaway for us was how there was this increasing invisibilization of this unpaid digital labor. Because as I started, posing that question at the beginning of the presentation, that whose labor is really building these systems and infrastructure, and whose digital labor is really sustaining this. So there are processes for these ASHA workers to basically document the kind of work that they do, and their payment and incentives are calculated on the basis of that. And we were quite surprised to see that on many of the occasions, there wasn't any provision for them to account for the digital work that they were doing. And most of the ushers in most of these in the states that we had studied were not getting paid for the digital labor that they were putting in. With the exception of, I think, Kerala, which was paying some marginal amounts for the work which the ashas were doing in collecting data for the Shelly app. So this was something which emerged as a major concern for us. And as we know that the larger context within which we are speaking is that ASHA workers from many states are on strike, asking for their worker rights and better pay conditions. So we have to be very mindful when this kind of digital labor additional work is added to their already expanding list of work. The other critical, I think, takeaway for us has been how there has been this increasing datafication of their care work. So when we talk about increasing focus on digital surveys and digital data collection, what really happens is then the digital data becomes more important than the service delivery itself. For example, ASHA workers, particularly from Haryana, had shared with us that how they were asked to focus on the registration of the Ayushman Bharat cards, and then possibly even at the expense of some of their regular ASHA work. But then we also saw through our study that what could be a contrasting case, for example, in the case of Rajasthan and Kerala, where the digital applications were actually supporting the community care work, whether it was through making the collected digital data accessible to the ASHA workers, as in the case of Rajasthan, or whether it was by keeping the pace of the digitalization slow, as in the case of Kerala, and very purposeful, related to the NCD data collection, which was very much instrumental in the work that they were doing on the ground with the community. So in those cases, we found that this data collection and the digitization has actually supported the ashas in their community care work. And we also found both in Kerala and Rajasthan that they were also using digital technology in innovative ways to even promote the community care work by using WhatsApp in innovative ways to share information with the community and to mobilize community for healthcare programs.
You
So
have
the key
5 minutes, Sri Rupa.
Yes, I mean, these are the last two slides.
Okay.
So the key recommendations based on our study are that we should be very, very seriously thinking about participatory approaches to co-designing digital tools. For example, like if you could take inspiration from what's happening in Kerala, in co-creating digital tools, digital tools that are context sensitive and user friendly, by involving ashas in the designing process. Another is having worker-friendly, worker-centric tools, like, for example, what we have seen in the case of Rajasthan's PCTS app, that allows ashas to streamline their work and access the data. So investment overall in digital infrastructure, I think, is critical for any digital transformation to be sustainable and effective. Reliable internet connectivity and access to good quality devices. I think it's a very important thing which the ASHA workers, excuse me, have kind of often spoken about, because some of the states have made available free smartphones to the ASHA workers, but they are often of very poor quality and are not easily usable for the ushers in their work. And we also emphasize how important gender responsive digital skilling is. Comprehensive digital skill development is critical. I think a lot of important areas that need to be taken into consideration are the language in which these training programs are transacted, and how to ensure that there isn't any exclusion in the way that these programs are run. Another critical thing which maybe I could pick up during the discussions and the Q&A is how social norms also play a very important role in the way that it limits women's access to technology. Just a moment. So to conclude, I think for us, it is very important that we need to reaffirm the centrality of Asha's voices and their participation in this whole process. And what we have understood in our study across these 4 states is the important role of the collectives as well. So collective action, as I had mentioned right at the beginning, when I spoke about the Asha work in Haryana, has been critical in challenging harmful digital data practice in the state. And at a time when the personal data protection was not even something that people were seriously talking about, this group of workers and the collective managed to push back a surveillance app, and which is, I think, remarkable. So the vision for the future for us should be that we have to be able to think about alternative ways of imagining a digitalized world of work. So new digital data futures based on more inclusive and participatory, I think, approaches, which recognizes the workers as partners in these processes, is something which I would want to leave you all with. So thank you.
Thank you so much, Sri Rupa. I think you gave a very broad overview, and I think it gives us a good context for the rest of the panel discussion. Also, I think important to remember that the ASHA worker at the end of the day is at the lowest rung of the hierarchy, the woman who's paid the least. And with within the system, she has like very little power. And this burdening of the ASHA, with a whole bunch of initiatives. We do say digital, but then at the end of the day, she's not being paid additional for any of that additional labor. And it's almost like the entire health system is resting on the shoulders of these women. So yeah, I think we as people who are working with the system or with communities should understand that it's not like as romantic the ASHA workers experiences, and it's good to take note of whatever you said. And now to introduce Dr. Narendra Gupta. He's a senior advisor at Prayas, and he's a community health physician, and he founded Prayas, which is based in Rajasthan. And he has mainly focused on health education and livelihood. He's also one of the national co-conveners of the Jan Swasthya Abhiyan, which advocates for universal healthcare, and also has been the convener for Medico Friends Circle. So he has played a role, quite a key role in designing the communitization aspect of the National Rural Health Mission. So basically, they brought in a component of, community monitoring, with using a report card system, and a village health and sanitation committee. He was also part of the 12th five-year plan working group, and he's been very active with his organization to push for the free medicine scheme in Rajasthan. And yeah, so over to Dr. Narendra Gupta. Do you have 15 minutes? Yeah.
Yeah. So thank you, Sylvia, and thanks to NBC that they have invited me to come and speak. Being a second speaker, you are left with not too much of matter to speak about. I think my previous speaker has spoken quite a lot about what the ground realities about digitization in the health system, public health system of India is. Let me add few more things in here, essentially about that. One of the things which I strongly feel, and I'll take it to the time when NRHM was getting designed, and there were this idea of forming committees I mean, there should be committees at the local level. So I insisted that there should be committee at every revenue village, and then there was a representative of the Ministry of Panchayati Raj, an additional secretary level officer, and she said, no, 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 we can't have it at a revenue village. We better have it at a level of panchayat, which is a cluster of villages. And I told her that there is a big difference between revenue village and a cluster of villages. What I'm trying to convey through this is this, that the level of understanding people sitting in Delhi about the grassroots are so very different than what actually the realities in grassroots are. And all these things which are designed, conceptualized, formulated, they are all formulated at the level where people to whom they have to, people who have to use those technologies have absolutely no stake in them when they were designed or idealized. So that's the main issue, that who had demanded digitization uh, for health system. If it is not the people who want to improve their health have not asked for it, then why has this been imposed? And why has this been imposed in a manner that it causes more, I would say, some ease, but lots of troubles? It's not simply one thing, which is that because it's not been planned and worked out with them. And Government of India, as was told, that has come out with a press release where it says that it is changing the architecture, the health infrastructure and the services, the way services are delivered and all those kind of things. But if you see at the grassroots, there are more challenges than digitization, and that digitization is adding to further complicate the issues. Let me cite an example for this. That since I work at the grassroots and I work with peripheral level workers till the district level health officers and then also recently with the medical college people as well, that at every level, more than half the posts are lying vacant of at the district level, sub-district level, most of the community health centers, which should have all the staff, including the specialists, hardly have any specialists. No, even the number of simple medical officers are also not there in the number as they should be. So now the kind of data and the kind of information which is demanded by them, that they have been doing all of this work, is so enormous that within this limited human resource of health which is there, if they begin to report on those set of information, let me just share with you a slide about this Asha Soft, which is called Asha Soft, and you see that desktop. I don't know. Can Dr. Sylvia, you upload this slide? I am not being okay. Okay, perhaps I can now go.
If you send it across, then we can share it.
I send it to you on WhatsApp.
Yeah,
Sorry.
sure.
Yeah. Can you share it from there? So it runs into several pages. What I wish to mention is that it runs into several pages. The kind of demand which is there in terms of that it should be made available on a real-time basis, and most of the information is such that for that you have to do whole lots of calculations and computations. If you don't do those computations, then you will end up, where have I gone here? Uh,
I'll just open it and I'll put it. You're talking about that soft claim, right?
right.
Okay, I'll put it up.
Okay, so if you see that, then you suddenly find that if that kind of information is to be shared, to be reported by a person who is the most peripheral person from the same village, barely literate, means literate to certain level, to report, and then how the most important thing is that how do they utilize that information and data. Some of the information and data is fine that they use in terms of uh, like they here we have in Rajasthan a app which was cited, PCTS, that they could get to know that these women require this kind of a service. But
That's the one, right?
yeah. So can this be scrolled? If you scroll it, yeah. So this is the monthly claim form which Asha has to submit every month to her A&M. That's the A&M of the sub center, and just go down. Yeah. So if you see, even it's a first page of it, then she has to give population, and in terms of population, the number of children born in previous month are to be added, the number of people who have died have to be removed, and then it's a plethora of information which she has to submit. And I've been asking them that how do you make use of this information? They said, we really don't make any use of this information unless otherwise we are asked by someone senior from our offices that you have to do this or you have to do this. That is the only thing which we could do through this. So what I am essentially pointing out is this, that of course digitization is needed, should be done, but unless otherwise it's been not demanded, or it's not been felt need of the people of that area, and felt need of the frontline workers or the people who have to act on this exercise remains very, very incomplete and causes more complexity than anything good. And in most of the places, like for ASHA workers, or even in some of the areas where PHCs are, the network is not there, electricity, 24 hours electricity is not there, they don't have a data backup system. So all kind of problems they come across. And because of this, what happens is that the kind of effect it should have in terms of services becoming better, there is absolutely no sign of it. That services have become better because of this. They have been able to do more efficiently, they work more efficiently. The similar thing happens with, there's another thing which has been talked a lot about is the telemedicine. And within this telemedicine, it has been it's been worked out that this nowadays these are called Arogya Mandirs. So Arogya Mandir sub-centers, there's a position of CHO. So in one of the block where we work, there are 8 sub-centers. In 8 sub-centers, there is only one CHO. And that CHO also has never ever used any telemedicine. Then PHCs also have system of telemedicine, and then PHC to CHC, CHC to district hospital to medical college hospital. And no telemedicine ever happens. It happens only when some function has to happen, some senior officer or some ministers are visiting and they have to showcase that this is the way the system works. But only till then. Otherwise, no use of even the telemedicine. Similarly, the same thing about the electronic health records. They have begun some pilot projects in some of the places where these doctors have been given tabs where they could write the prescription, and then the patient goes to that pharmacist and shows the slip and then gets the medicine from there. But even that has not worked very efficiently. There are all the time glitches in there, and the health as I said, that most of these health workers, ANMs, and also ASHA workers, and even other senior levels spend whole lots of their time in collecting data, putting that data into the system, transmitting that data, and then just forget about it. Beyond that, they don't know what happens with with that data. And I could tell you with certainty that this data which is sent through this system also is highly unreliable. It's not at all reliable. It's exactly the same thing. The people who have been left out earlier are still left out. Like if a woman who's not registered, her pregnancy is not registered, she was not, left out even when there was offline system, and she's also still left out when the online system. So the digitization is, not expanding and bringing in more efficiency in terms of the delivery of services. It's in fact a whole lots of time is spent by these workers in terms of filling up this information which they have to transmit.
With 5 minutes, Dr. Narendra.
Yeah. So what exactly is needed? What exactly is needed is not that this is a digitization which is going to make any kind of a difference in terms of the quality of services, accessibility of services, and the ultimate outcome from the services. It's not going to do it. It's going to do it only when that the decentralization begins to happen. Decentralization in the things that, in terms of like the village health sanitation committees were formed that in 2005, and till today they are not functioning. The allocation of rupees 10,000 per year for every committee was decided at that time. It is still 10,000, and most of the places it is not even disbursed. That is the kind of a situation which we are placed in. And it happens because there's so much of centralization of everything. So till the time this centralization continues to happen, any amount of innovations in terms of digitization or in terms of bringing in more instruments or technologies are not going to make much of difference. These are going to make these things would make difference only when these people are part of the whole system in which these things happen, and the emphasis is more on output rather than in terms of introducing more and more gazettes and more systems and more things. Because I've seen that quite a lot of ashas here in our area even do not have the required app in which they have to report. And then we ask them, how are you reporting? So then they'll say, no, it's in the phone of my daughter-in-law or my son or my husband, and they do it on my behalf. That is the way it happens. So essentially, unless otherwise, things are that people should be explained that there's this technology, and this technology can be used for making the services and the systems better, so that you get better and more efficient kind of a more systematic way of delivery of services. If you wish, then this technology would be made available. Otherwise, it would not be made available unless that kind of a system. And see, the whole thing is this, that these workers, even at the district level, have no idea in terms of how and why it should be used. I have asked umpteen times from them that, do you look at this data which is being collected, and based on that data, do you do any kind of analysis, and based on that analysis, you plan out something? None of it happens. And if these things don't happen, then the people, they are only part of the system where they are just passing on information from one end to the another end, and they are in between, and beyond that they don't do it. They are just waiting for something to come, either from the center, at best from a state, but most of the time it comes from the center and down to state, to district and all. So the everything which originates from the center, by the time it reaches to the periphery, had diluted to an extent that it loses all its intensity and all the spirit under which it has been conceived and created. And these things haven't changed over the years. While the time has come that these things begin to change now very, very urgently, because there was a time when you needed national programs, I strongly feel, because there was not enough competence available, uh, so much of people, skilled people and competent people available. So you have to have national kind of things. But things have changed so much now that not only state, but district should be autonomous units in terms of deciding the way as they should be, delivering the health care services of their district, rather than everything is flowing from there. And the whole lots of institutions and systems, further strengthen this kind of a way in which things which should happen are not happening. And unfortunately, I shouldn't say so, but I have to say this, that unfortunately things not even flow from national level. Things flow from WHO or some international bodies to national level to state and so on and so forth. So the the ability of people, their abilities are not getting built up, and digitization is further weakening their abilities. That is what I sometimes feel, because it has not been demanded by them, it has not been conceived by them, it has not been conceptualized by them. And that level of conceptualization has to begin, if not completely at the periphery, then definitely at the district level. And those things will begin to happen. The effect of any new technology which we bring in would make tremendous impact in terms of improvement of services, both in quality and quantity. So this is what I wanted to say. Thank you. I think I finished in time.
Thank you, Dr. Narendra. That was an excellent presentation. Lots of points for our discussion. But I think let's move on. We have quite a number of questions gathered. But I think let's complete our presentations and then we'll get back to those. May I request Dr. Usha for her final presentation. Dr. Usha works on the jurisprudence of law, poverty, and rights. She researches rights and speaks on issues that include the nature of law, Bhopal gas disaster, mass displacement, eminent domain, manual scavenging and civil liberties, including the death penalty, beggary, criminal law, custodian institutions, the environment, and judicial process. She has been tracking and engaging with Indian National ID Project and has written and debated extensively on the subject. She has been writing and debating issues of technology and human conditions of freedom and liberty over the years. Over to you, Dr. Usha. Thank you.
Thank you. Having heard the other two presentations, I think I'm going to change my presentation around and say what I had intended to say last first, because I think that may address some of the kinds of questions that we have about why data is being collected, why is it that it's not being used at the grassroots, why is it that people who are collecting data are told nothing about what they do with that data, why is there not a participatory process? I think some of these questions will find at least a partial answer in something that happened earlier this year in January of 2025. To come to that, I'll just go back a little bit. See, when digitization was started, along with when the Knowledge Commission, they had one whole segment on technology, and they said that one of the things that needs to be done is digitization. So digitize all legacy databases, but anything happening after this should only be in digital format. And it wasn't very clear other than to say that maybe it will be more efficient if we were going to have everything in the digital format. Other than that, there was really no explanation of how that would be better, because we are in fact dealing with and I think that's come out in the presentations too, we are dealing with a situation where it's kind of partial literacy, semi-literate, also illiterate, asking people to learn various skills and various methods of communication, which require which it would help if there were a greater level of education for people, of literacy for people. We find that that's not there. So digitization per se would in fact produce more problems than otherwise. And I think that's something that Dr. Narendra Gupta has adverted to quite strongly, saying that, listen, all manner of things are passing off as data, and it's going wherever it's going. So I think it is important to understand, I don't know if you're understanding it, but at least to query and to try and find an understanding for why this emphasis, this, such a lot of pressure on collecting data and making every person a data gatherer as their primary activity. Why is that happening? When the project first started, when the UID project first started, so digitization began around 2002, 3, 4, 5. Actually, it's around 5, 6 that they brought in the National Knowledge Commission report. And then digitization began. And very soon after that was the ID project. And the two got linked up because everything digitized had to have the ID in it. And we needed to understand why. Why does some database about somebody's health have to do with their ID being linked to it? Why can't they get their treatment without their ID having to be linked to it? And we find that this is something that, I've said so often, I think I feel like I'm saying it in my sleep now, but it is that, they were looking for something that would be unique, which would be a unique number, universal, so that everybody should have it, And to achieve it being universal, it had to be ubiquitous, which meant that it had to be in every database. Now, very soon it became obvious that the agenda really was, I mean, we must also remember that the person who came into the government to help in rolling out this project, who was also the author of the Knowledge Commission report on technology, Mr. Nandan Nilekani, comes from business. His interest is in making sure that there is profit making for businesses. And in this case, very, very effectively, to make the state work for business. So the power of the state to push people to do certain things, the power of the state to change the ways in which people who work, under the aegis of the state work, to make that something that is voluntary into something that is mandatory, to coerce people into various situations, to deny services if they do not conform. All of this is something that could be achieved through the state. And initially it was a hypothesis, and then very soon we found that there were a lot of things happened. And then in 2016, when the Aadhaar Act came in, they explicitly said there in section 57 that all companies should be able to use this database because then they can build their business on it. We also remember that know your citizen became know your resident, became know your customer. And KYC today, with something that's a national ID, is about knowing your customer. So it's an important transition that happened. In 2018, the Supreme Court struck that down. I mean, honestly, I think the majority judgment struck it down because they found they could not sustain the law if they had that provision in the law. So they struck it down and said private companies cannot be seen using this data, using this database. Immediately there was an outcry, and then within a year, or in just over a year, the government, having promised business interests that they would make sure that they could use this database, they made an amendment to the Aadhaar Act allowing companies to use this data. It's also interesting that when the case was pending in the court, among those who approached the court saying, please don't do anything to this project, allow it to continue as it is, were 5 companies which said that our work depends upon the continuation of this project, where the ID will get linked up with all kinds of things. We should be allowed to make it mandatory, that whole range of things. Then after 2019, in 2020, as a follow-up to the 2019 law, there were rules that were made. And those rules, just give me half a second, those rules were called the Aadhaar Authentication for Good Governance, Social Welfare, Innovation, Knowledge Rules 2020. Now, under this law, under these rules, they made it explicit that Aadhaar authentication could be by requesting entities only in the interest of good governance, preventing leakage of public funds, promoting ease of living of residents, and enabling better access to services for them. So it had to come within this chapeau. In 2025, the mask has actually been taken off. Early this year, they said that this part of their rules, which says that it is only to be used in the interest of good governance, preventing leakage of public funds, promoting ease of living of residents, and enabling better access of services to them, that should be deleted entirely from the rules. And in the purposes for which it can be used, they said promoting ease of living of residents and enabling better access to services for them, which is basically like Ashwini Vaishnav said, it is so that private industry will be allowed to use this data and to create products to make it better for people. The more products they create, the better it is for us. Basically, that whole logic that this project is for providing good governance and services and to prevent leakage, that has been taken off the board. So I think we should just stop thinking about this in terms of, all those public purposes for which they said that they were going to do it. They are not saying it themselves anymore. They've taken it out. And they've said one of the purposes, if you want, you can use it for preventing leakage, but private industry now should be allowed to use all this data so that they can make products. And that is their idea. So they have ease of doing business on the one hand, and provide access to better services, which means industry has to be able to produce better services and to be able to reach you, to give you those services. So the object of this whole idea of digitization and producing an identity, which right in the beginning they said would be, so that poor people, vulnerable people who don't have any other ID, they will be able to access their entitlements. Now that has given place entirely to private industry, and private industry using that data to doing what they want with it. So I think, and this does not exclude health data at all. In fact, health data is central to this, because after financial data, they've been looking at a range of other things. So it's money, which is UPI and all the rest of it. And then they are looking at health, education. These are the places where they are looking for data. In the national health stack, which was prepared by the UPA, the fact that you have this health stack itself comes from private industry. There's a private industry body which has been pushing for what they call the India stack, and that has got adopted by the government. So maybe when we think about what is happening in the field, we need to think about it also recognizing that the objective is not really delivery of services. The objective is the creation of more and more products. It's also important that the Sri Krishna Committee report on privacy, which was supposed to be on privacy and on data protection, actually declares itself as being for creating a digital economy. And in 2021, they had the UIDAI organized a 3-day symposium called Aadhaar 2.0. And two of the people who were originally in the UIDAI, Mr. Ramsevak Sharma and Mr. AP Singh, they were in a session where they said, what is this? What is happening with all this? We created this, we created all of this because we were looking for creating a digital economy. This does not belong to the government. Why is the UIDAI acting as if they are gatekeepers for the data that has been collected and given to them? It is actually for creating a digital economy. So make it open, make it accessible to the public, to industry. Now we find, along with that there is the whole idea of data sharing policy that has come from the state. The state claims property over all the data that is being collected, and then it decides who it's going to give the data to. Not only that, it also decides who will have liability if they misuse the data or lose the data or it gets stolen from them. What happens in such a case? For instance, they say startups should be exempted from all of this, because startup culture is the culture we have today, where you use all that you have, you create. The whole idea of a startup is you start up, and then if it fails, it fails. But out of every so many, there will be something that will become a unicorn, and then it will become very big. Because all this data and the data collection that's happening now, the idea is to become some kind of a leader on technologically derived data in the world market. So if you look at all the conversations happening, for instance, if you look at what happened during G20, they were able to push the financialization of all of this, how they brought it into finance. They want to do this in every sector. This is also a World Economic Forum idea that we are, this is the fourth industrial revolution, and either you lead or you get left behind. So our imagination in that sense, I think, may have to be tutored by that. Increasingly, they're also drawing, full stop, paragraph, maybe chapter. I'll move to the next thing, which is that there's also a distinction that's being made between digitization and digitalization. It's still kind of hazy, but the basic idea is that put everything in digital format, and then we'll figure out how to use it. The use of that will be digitalization. So conflating these two would also not be a great idea. In the health sector especially, since questions of consent, confidentiality, and anonymity are so important, it's also important to remember that there is this idea that has developed, that has come from industry. There was a committee on non-personal data governance that was set up with another of the Infosys persons, one Chris, whatever his name is, being in charge. And in that, they brought this idea of non-personal data. Non-personal data being data that belongs to the person. It's also all climate data and highway data and whatever, but it's also all data that is about a person, which is basically personal data, but which is already in the public domain. or which has been anonymized. I think by now, the myth of anonymization has been exploded multiple times, but it provides a fig leaf. And the idea is that to collect all of this, and once the state has any information, so when we talk about not having centralization, we should decentralize it. Technology provides great opportunity for centralization, and the temptation to centralize is very strong. And it is, in fact, the objective of this whole exercise is centralization, which is why they don't care, the ASHA worker doesn't need to know why she's collecting data or even what it is. You just send that information on, and then we'll figure out what to do with it. So this is the other interesting thing about this field, where nobody yet knows. You collect all this data and then you don't yet know where you're headed with it. But you give me all that material, let me see what I can do with it. So they are opening it out for a whole ecosystem to come in, take that data and figure out what they can do with it. So health data is a similar kind of thing. There is there are some notions that have come in this context, especially on artificial intelligence, which you've perhaps already discussed, I don't know. One is this idea of singularity. And it took me a very long time, I must confess. I mean, I feel pretty dense. It took me a long time to understand because I couldn't believe that this is what it could mean. So singularity seems to be the point at which the human merges with the machine, basically. Long and short of it is the human merges with the machine. And in this, one of the ideas that has come along with this is this thing called human augmentation, which is that the human as we are now are inefficient. We are, we are weak. We don't know our own strengths, even if we have strengths. And it's important for the machine to be able to figure out what we are. This is especially in the defense sector, and it's expanding into many other sectors, where they say that we have to augment ourselves by our interface with the machine. And that's the only way that we are going to find what it is that we are doing. The other thing that we do need to remember is, actually speaking at a time like now makes this conversation very easy to understand. You have Elon Musk sitting there saying, I want all the data from everywhere. I will do what I want with it. Today we hear that he has palmed off X to another X AI company, which is also his, saying that we want to merge these two so that he wants to use that data to produce more and more artificial intelligence. So I'm sure everyone has said this. Yeah, sure. I'm sure everyone has said this, but this idea that artificial intelligence depends entirely, depends to a great extent anyway, on the kind of data that has already been collected. And as data keeps coming, so the data biases is something that we've talked about for the longest time. And everybody knows that artificial intelligence comes with biases. Now, then they talk about machine learning. Now you're talking about Grok, which has its own way. It does it. So machines also do their own thinking, and it produces what it produces. One phenomenon that I want to mention, because it's time is short, I'll just stop with that and say this, is this notion that has come in of disintermediation. See, when the IAS and ICS, whatever were there, the idea was that they will act as an intermediary between the state and the people. Now that has been sliding down over a period of time, and technology, when it came in, they were promised that this would help to disintermediate, which means they don't have to mediate, they don't have to have a direct relationship with people. Their relationship will come through data. So if ASHA workers are sending in all that data, that is the basis on which all policy will be made. People don't, officials don't come to the field anymore. They should not. And Niti Aayog has actually gone as far as to suggest that if officials meet people, there is room for corruption. But speaking through technology means that corruption will not happen. Now, one of the things that, there are many things to say about it, but I'll just say one thing, which is that disintermediation has this way of taking responsibility away from the human actor. And they can step back and say, I don't know. This is what the data says. And we've seen huge kinds of problems that come with it. Just one word on exclusion before I stop. Recently, there was a report on how 10-odd crore people had their NREGA job cards struck off. And when, people were protesting, saying, what do you mean? That's like 1/6 of those who are on NREGA. How are you just striking all of us off? And Now they've said, no, we've struck you off because you don't fit this, you haven't managed to fulfill all that you need to fulfill digitally. Now we will go to the Gram Sabha, and the Gram Sabha will have to look at each of these people who've been struck off and check out whether they have migrated from there, whether that Gram Sabha or that, whether that village or that panchayat has been merged with some urban sector, in which case you no longer have NREGA job cards, or you have died. So after excluding people, a certain onus will be put on the local to deliver. And this seems to be, this is the model this is the latest to emerge. So it's to say, and I'll just wind up with this, that the idea of digitization, identity, digitalization, AI, and the ambitions that are pinning on to creating economies around data, and the state having control over all of this. It's not just having it in their physical possession, but even that which is not in their possession, they have control over all of this and over people. That is the kind of ecosystem in which we'll have to think about what data means, what digitization means, and what artificial intelligence means, especially in the context of health. Thank you.
Thank you so much, Dr. Usha. It was very thoughtful comments and thoughts. Sylvia, over to you.
Yeah, thank you. Hamad, do you want to just give a short description of like what you're doing? And then we have a couple of questions and then we can have the discussion. It'd be interesting to get like a sense of what's happening in the area where you're working and a kind of perspective based on these three presentations.
Yeah, thank you. Being in Canada, I think it's and working globally gives me a perspective to look at both the sides more holistically. In Canada, we are moving forward with our digital 2.0 digital health strategy for the province I'm living in, Ontario. People are using AI in doctor-patient communication, getting their notes. AI is recording, presenting the doctors, and they are moving ahead. We have electronic medical record at the primary care level, now linking up with the hospital information systems, and all of that structure, and the projects I'm involved in globally for instance, one project in Pakistan where we are using a digital app for helping patients check they get their reminders for their blood pressure medication, and similar challenges which all of the three participants have shared. I've seen on ground from those projects. So these two are quite different. Focusing on our side of the world, which is still struggling with a solid digital infrastructure. I think that is a challenge which we don't realize. We don't consider that it's very small, but it's a huge challenge. We don't have the right digital infrastructure in rural areas of where we work. We have patients who are semi-literate or illiterate, who don't know how to use any application. They don't have a smartphone. They are dependent on their family members for any communication. And that's the struggle that we are facing. We thought it would be easier. I was involved in an RCT, and we saw that people just don't have the smartphones. They rely on their sons, their daughters, the other family members. Women especially are excluded. They are just supposed to work and take care of the house. And one of the women which I talked to was, she said, she was a young, like fairly young woman, but hypertensive. She told me my mother-in-law keeps a check on me on how much mobile I'm using. She had a smartphone. She said, my husband got this for me as a wedding present, but my mother-in-law thinks I use TikTok all the time. So I can't check the app because whenever I pick it up, she's there and she tells me not to do it. And there are other women who just don't have a cell phone. They're dependent upon their husband and other family members. So this is the patient side, but coming back to the frontline healthcare worker side, their challenges, like Dr. Sri Rupa said, are immense. They are told to use multiple apps and send data to the secondary, from the primary healthcare centers to the secondary and to other areas and to other projects, but they are not paid for that. So all of these challenges, I would request everybody to focus and read on these frontline healthcare bureaucrats, because there is an article which calls them frontline healthcare workers as street level bureaucrats. And these street level bureaucrats are the one which should be involved in a bottom up decision making process, so that whatever digitalization we are doing on ground, these we get them involved. I'll just stop here. There are so many points I've listed down, but I know we are short on time. I'll just open it up for dark questions.
Yeah, so we do have a few comments and questions. Sushil Matthew John says, what are the key ethical and legal issues regarding the digitization of work of the ASHAs? And Anil Sharma says, even NGOs are promoting digitalization without considering how the employees are accustomed to such technology. Data is more important to them. Alban Sigamani says, how can we segregate the challenges of digitalization from poorly designed systems and inefficient management? And Sunanda has asked specifically to Sri Rupa, are the ASHA workers competent enough to use AI, that is health-related tools and techniques? Are they able or competent enough to understand the machines and the logic algorithms? And like Sri Rupa, you mentioned old ASHA workers. Is there a difference between the older workers and the younger or probably more professional workers? Are there geopolitical hindrances? And what are the geopolitical in addition to the societal hindrances that the workers have been facing? Again, Sunanda Das asks Usha Ramanathan, professional ASHA workers do use digital tools and techniques. Are they ethically sound? And to make them highly professional, the government has the government taken any initiatives? And if so, why are they facing obstacles and where are the lacunae? And one point again from Dr. Linda to Usha, that while we can think about what this introduction of tech and AI means in the milieu that we exist in, how can opinions on ethics and justice be conveyed to those that are making public health decisions? It appears that these interventions will be rolled out whatever we think. And what are the democratic options that we have, if any? If Usha can go first, then Sri Rupa, and if Narendra has anything, and then Hamad. So I guess we have enough time to have one round of discussions.
So I'm going to do a little bit of cheating and also answer a question. I mean, just contribute to an answer to a question, to the one on NGOs. I think a lot of the time we do hear people say, and I think we also had this in our conversation here, that people who are having to collect the data or to work with the data in whatever way should that it's a problem that that there is no participatory method and that they should be allowed to participate. I think I'm not sure I would go that route at all, because actually it's very difficult to understand. You know, when people say that you just have to collect this data and you have to give it, you have to fill up these forms, to understand what goes behind this, what is going to happen with this, to be able to, you know, imagine that and to know what it does, for instance, about consent of people and what responsibility, how much more responsibility can you give to an ASHA worker to say that make sure that there is consent and make sure that confidentiality is maintained. It's not even possible. And for them to now think about what the global agenda is on this. I think the big problem is also, this is also the big problem when it comes to non-governmental organizations, because they're also being sold it in a certain way. I mean, you have to be able to dig into it far deeper, to know what questions to ask, and not to proceed if you don't get answers to those. So a lot of the time, even, I mean, every one of these stages we found that NGOs do participate in it. It also comes because of our easy adoption of any technology given to us. I mean, they give you a desktop, you took a desktop, they give you a laptop, they take laptop, they give you whatever notebook or whatever other book there is, they give you a phone, you take it, it becomes smartphone, you take it. So there is no questioning at all. If at the end of a process of questioning, we take it, it's okay. But it's like, if it's technology, you have to have it. So that, whatever hold it is that technology has on people, I don't think NGOs in any way escape that. So I really think that the questioning has...
Just one small point you can clarify. There was time when we were doing like manual data entry.
Yeah.
The front line. I'm just taking the devil's advocate. There were people who were filling the data and passing it manually, and now we are doing it digitally. At that time also, they were not asked, which I suppose, and they were just being
Correct.
And now also it's the same.
Correct.
What's the difference? And
the consequences are very different. The consequences, the implications of having this in a digital database where you are contributing to centralization and control over data, that's a huge difference. See, the inefficiencies of the earlier system were certainly legion, but we are assuming that there is efficiency and nothing else to worry about in this system. So we have multiplicity of problems. One, we have the centralization of data. Then we don't know what is done with the data. Now you have a state which says, I mean, during the case in court, the Attorney General actually raised a question. I didn't believe he could say such a thing, that what makes them, because, we were talking about biometrics and asking for our biometric data. And he said, what makes them think that their body is their own? Meaning it belongs to the state. So, it's a very different world we live in now. And there is a closeness between, see, the state itself doesn't know how to handle technology. So they bring in the persons from the world of technology, and then, they adopt whatever is given to them. In fact, somebody like Nilekani and his team have said that this is about evangelizing to the state the products that they make, which will help in creating more and more businesses for them. The India stack is really about e-sign, KYC, e-KYC, e-this and e-that, and DigiLocker, all the kinds of products that they want to be introduced into the state system. That's very different from what we had before. I mean, and the big advantage, I think, is that our earlier records could be eaten up by rats and we would save ourselves. Oh, I think we'll have to punch holes in them. I don't know what you can do. So it's a flippant side of it, but I think there is also an element of seriousness in what I'm saying.
Absolutely.
Yeah? So the second thing on ethics, I'm often told that we shouldn't talk ethics when it comes to technology, that technology really has no ethics. Technology is it's a tool, but it's a tool in the hands of some people. It is being given to us like we don't have a choice. I believe we do have a choice, and I believe we need to exercise that choice. But we have, especially in India, see, they experimented with this biometric identity and whatnot in many places. It's in India that they found an obedient and compliant population, which is shocking given the amount of democratic movements there are in this country. So I at least believe that it's because we didn't, when land was taken away, we knew something tangible was being taken away. We don't know what is being done when it is with technology. It's hidden. You don't know. If if this kind of thing were to happen with anything that was visible and they could see what was happening with it, the reaction would be very different. So that's something, yeah, they do believe they own our bodies. How do you think they're asking us to just give whatever it is that they want? And why are we giving it? That's also a question. So, this idea that, can we have better management? Can we have, can it get better? Sure, it can get better. I mean, there will be glitches, it'll get better. Everything has improved over time. Actually, we are not where we were 70 years ago, or 50 years ago, 40 years ago. Many things have improved. Many things have changed anyway, whether they've improved or not. But is that what we want? And I think there needs to be some kind of an understanding of that. For doctors, this AI is going to be, I'm sure you see this all the time. For doctors, it is important, when AI says, for instance, if they have to consult, what AI has to say, what it's saying about whatever course of treatment or diagnosis or whatever on the basis of that, of what is fed into it. If the doctor differs from what is being offered to them by technology, and there is something happens which may have happened anyway, the implication for the doctor is pretty serious. So the temptation will be not to take a position which is contrary to what is being offered by technology. This is something we are seeing among the bureaucracy already, and it's likely to happen when it comes to the medical profession too. Why would you want to take a risk of medical negligence when some technology is looked at everything across the globe and is telling you this is what you need to do? You as a doctor with your instinct and experience may believe that this is not what you should do. But if you take that position, you put yourself at risk. And the question is, how many people will feel strong enough to take that risk? So the idea that people treat people and that technology is a tool that they may use is now giving place to professionals having to use technology to decide what to do with people. And that shift doesn't require just ethics. It requires something more. I really don't think, I am working on something called a philosophy for technology, but I do not think that ethics is going to be the salvation for us.
So, we had some comments based on what you're saying. Brinda says that it's unbelievable that the state actually believes that they own our bodies. And Nilesh Gowde says that earlier the data used to remain in the register of the frontline workers, and only aggregate data would go up and the frontline worker would provide services. Now with digitization, the individual level data is available to, at all levels. Sayantan says, Usha's talk is so moving and I'm so happy that I'm in this audience. And Olinda, and Sunita says that the first policy document, white paper of the Niti Aayog on AI in 2018 was weaved around India to become the leader in data mining and data commodification. It was all about the commercial potential of data corpuses that India can generate with population size and its implication for strengthening India's digital data. Over to Sri Rupa, because you had some points and questions, and Narendra. Actually, we end officially supposed to end in about 2 or 3 minutes, but the organizers said we can go on up to another 10 to 15 minutes. So.
So yeah,
Rupa.
I'll also like to speak.
Yes, Narendra.
Yeah.
After Sri Rupa, Narendra, and then Hamad with his thoughts, and then we close. Yeah, Sri Rupa.
If you can start with this question on the competency of the frontline healthcare workers, the ASHA workers. I can generalize them as frontline healthcare workers. Start with that question. Over to you, please.
Sure. I think that's precisely one of the important things that we also started looking at when we were looking at the digitalization of ASHA's work, because we have to understand the context that the ASHA was started way back in 2005, and they were imagined as basically volunteers. as you know, community members who could just facilitate the mobilization of the community and increase public awareness. So the qualification that was required at the point of recruitment of these ashas were just, as low as 4th class pass, as I was mentioning earlier. So, but over the years, there have been an array of tasks that have been added onto the already big list of tasks that the ASHA workers had to do. And with the digital transformation, now we have something which is much more of a technical skill, so to speak, that the ASHA workers are now being asked to do. I would also like to comment here about how even in the recruitment process of these ASHA workers, a lot of transformation has happened. For example, I can cite the example of Haryana, where they have changed the recruitment criteria. They have brought in a point system wherein highly qualified candidates would be given higher weightage. So the more qualified you are getting a higher weightage. So earlier, where the criteria was how closely connected you are with the community, you used to get a weightage in terms of the community care that you are providing. Now the expectation is of a more qualified candidate to be taken in as an ASHA worker. So having said that, and something which I mentioned earlier also, this group of workers is not a homogeneous group. And there's a huge diversity, especially if you're looking across the country, from a very low literacy level workers to somebody like a graduate or somebody who is qualified as an A&M joining as an ASHA worker. So their capability also on those lines is really diverse, and what they have received in terms of the training and skilling from the state is also very diverse. As I mentioned, like for example, in Kerala, they had an Akshaya Center which was providing digital skilling and access to all the citizens. And because of that, ASHAs across board benefited. And when one of the specific questions was about older ASHAs, and I wouldn't want to generalize and say that the older ASHAs are the ones who are struggling, because especially we saw in the case of Kerala, where they were exposed to digital skilling and where they were given sufficient support, they were able to make that transition. And I think it would be, we would be cautious about saying that, because as I mentioned, there are changes that are happening within the recruitment process. They already feel excluded and marginalized within the changes, and some of them were very vocal about feeling that they are being really marginalized in the kind of trainings that's going on. I think the couple of other points, one of the important ones which I would like to touch upon was about the gender norms. And this is so critical, and I think Dr. Ahmad also mentioned about it, that women, the kind of access they have to technology is highly gendered. There are very different rules for men and women about how they get to use technology. And in cases of states like Haryana, where we saw that the state had given a smartphone to each of the ASHA workers, yet having a mechanical access to the smartphone was not enough. And we found that the ASHA workers in Haryana mentioned how they have this system of keeping a parda or a veil while they are in the public spaces, and have to be very measured in the way that they conduct themselves. They say that if they get a phone call with regard to their work, when they are walking on the street going for their work, they would not be able to simply pick the call. They would put it on possibly, a speaker, keep it away from them, pretend that they are not speaking over the phone because they will be judged. And they spoke about how there will be conversations about, how women who use phone in the public on the street are seen as with moral, questions about their morality. Similarly, many other ashas also mentioned how this could be also a point of contention within families, that how much time you're spending on the phone. There can be, questions asked by husbands and mother-in-laws, as you had mentioned. And particularly during COVID times, ASHA workers had to face even domestic violence when there were trust issues in the family about their use of phone, which could very well be related to their work.
Thank you. We have this question from how can we segregate the challenges of digitalization from poorly designed system and inefficient management? I can request Dr. Narendra if he wants to take this question, or any other points which he wants to
Yeah.
his.
So I am a person all my life. I have worked that there should be some kind of an end point we should get out of whatever thing which we do. So I have always worked on those lines. Based on all our discussion which we had so far, I have just a kind of sense that we still are looking at these things in a very elitist mode, in a very, top-down mode. The time has come. Even in 2005, I had to struggle, literally fight with the system in terms of pushing for that there should be these village health sanitation committees which begin to do health planning. Which why I am stressing this point of health planning, because the need for digitization should come from that body, that we need digitization of the health services for our purposes, rather than somebody else deciding and all the time pushing and dumping on them. Though the system has to go upside down completely, unless otherwise the system doesn't go upside down. Instead of, as Dr. Durrani also said, that it should be bottom up. What that bottom up is going to be? See, why these VHSCs are not functioning? Because it is not the central center which doesn't want them to function. That is the whole point. So the role of the center, the role of the state should be that we have this technology, do you want to take it? Rather than pushing and thirsting on them that you have to have it. This is what we demand you to do it, because we control the purse string. We have the control over the purses. That should not be the approach. That approach has to completely change. Unless that approach is not going to change, things are not going to change. See, let me give you another point. On World TB Day, everybody is talking that we are not going to attain those targets which were fixed for 2025, even in 2030. Why are we not going to achieve these? Because the conditions under which people are getting affected by TB are not changing. So you are just catching those people who already have been infected. How are you going to, stop it when there are people who are all the time, getting infected because of their own socioeconomic conditions? So those are the things, unless we do not stress on, unless center doesn't give up its authority, state doesn't give up its authority, state governments don't give up their authority, they don't impose these kind of things which they borrow from somewhere else. They are not even original of their own. They borrow from somewhere else and then try to impose and push on people. So that is the whole thing. And unless we do not change, things are not going to change. That is what precisely, and that is the reason most of the targets in 2000, 2015, now 2030, and maybe another 15 years, these things will go on and on. So it's the same thing happens for digitization. It's a tool. It's a very, very good tool. The tool can be best used when the people who want to use it, if they don't want to use it and if they don't understand the importance of it, how would that make any difference? It won't make any difference. And that is the kind of a culture which has been built in. So if you talk to Ashas do not see, when Asha, the cadre of Asha was created, they were thought to be the activists. No, that is the way it is. Asha is accredited social health actors. But where's the activism? Activism has completely disappeared, because that is the way the people in the corridors of power want them to be. They want them to be the lowest rung of the health hierarchy. So these things have to change. Unless those things are not going to change, things will continue to remain the same, and we'll keep on discussing it like this. Thank you.
Thank you so much, Dr. Indra. Totally agree with what you said on every session needs to conclude in a way that we take some positives from it, and we understand or at least our thinking gets a bit more cleared that what should be the path. People might disagree, but we have this issue where the frontline healthcare workers are overburdened with multiple roles. We also agree digitalization is happening. It will continue to happen. It will continue to improve. People have used the technology in a better way, in a manner that is helping them, even in rural areas, urban areas. That is undeniable. But in healthcare, we just give you a small example. I went to a primary healthcare facility over here in Canada. I was blown away. They were using they had their own dashboard. They were using monthly data, seeing how patients are coming, who's coming, what, like all of the patient information was there. And they made decisions on that based on that dashboard. I was really surprised, and they were still struggling that they are doing this with limited workforce, and the IT support is not there, and all of that. So in countries like India and Pakistan and Bangladesh and other where we struggle with providing the basic infrastructure, I think if the governments want to digitalize, they want to have convert data gathering techniques from manual to digital, okay, you do it, but you need to strengthen the digital infrastructure. If you need to give more human health resource, like put in extra workers in IT support, and they will manage. Expecting the currently overloaded frontline healthcare staff to do additional job of doing multiple gatherer of digital data, like Dr. Sri Rupa said, it's very hard for them. They need to, if you don't have that space, you need to train them properly, incentivize them, and keep on repeating the training. Data should come back to the center. There should be a mechanism where what Dr. Usha said, that when data goes, we don't know what's going on. It needs to come back and to show that this is what you have collected. This is your center's data. Use it as you please, and this is how we are using. So bring them, take them in confidence. The bottom-up approach, people usually don't like it, but I think that's where we involve our street-level bureaucrats in policy-making process. Any last comments from any of our presenters?
If I may, I just thought that this might be
Please.
important that the ASHA workers also spoke about the mental health challenge which they are facing because of this increasing digitalization of their work. And I think when we speak about the frontline workers, we honor them, but this is something that we miss. So thank you.
Absolutely. Thank you so much.
So essentially, they feel these mental health issues because of the kind of pressure put on them by their seniors all the time, every time. They don't enjoy the work. See, the essential thing is that unless you don't begin to enjoy the work which you are doing, and that is the way this cadre was created. This cadre was created that they'll be activists, they'll be bridge between the people of their own village and the health system. That bridge thing has completely gone. Now it's all, something that they are part of the system and they are under tremendous pressure for everything which this health department wants to do. So naturally, they don't enjoy the work. They feel the entire work as a big burden on them. And they do their work, and then they also have to do their own work in the families, and then there are systems, cultures. If she's a daughter-in-law, young daughter-in-law, she has to, respect her seniors, and seniors have different views, and all kind of things happen. Unless people do not begin to enjoy their work, performance will never ever become better, whatever the tools we bring in. That is what it is.
Yes, Dr. Narendra, performance measurement is another thing which is there in spite of all of this work. Thank you so much, everybody. Over to you, Sylvia, unless Dr. Usha, you have anything to say?
Yeah, just a quick
Please.
word. because I think one of the participants has asked, there's always risk-benefit analysis, and shouldn't we also look at the benefits of this? I think what we are being sold is the benefit of this, and we need to learn to look at it critically. So if the objective towards which it's being lent, all this data is being lent, is something so different and distant from what we are looking at, I don't think we can do a standard risk-benefit analysis. There are certain situations where that simply hasn't worked. For instance, if you take mass demolition, demolition of juggi, squatter settlements, in these we can't be talking, we can't be talking about it in the same way as we would if you're just looking at a project of, where there is a balance that can be drawn. This is one such, and I think we should be careful about, we've been told that people are corrupt, people use black money, people steal things. So we've been taught in this process to think about us as less, and therefore we need to be documented all the time to make sure that we are not, criminally inclined. I don't think we should accept this, and which is why I'm saying that I'm not sure it's about a risk benefit at all. It's about learning to see it and having a clearer understanding rather than just adopting language that's being given to us. That's all.
So, I mean, there are a few more comments. I think most of them have appreciated the speakers and, the kind of inputs that have been given today. And yeah, I think the take-home lesson is that you can't have, you can't digitalize or digitize without a functioning health system, which we clearly don't have. It's like the myth of, that once you digitalize it, then the health is going to drastically improve. It's not going to. We need human resources, we need budget, we need, all levels of actual healthcare infrastructure and, systems to be put in place. Most places don't even have blood banks, they don't even have drugs, they don't have basic testing facilities. You go to a district hospital, you don't have, sometimes beyond paracetamol, the doctors don't have medicines to work with. There's a whole corporatization of healthcare that is happening. And, the telemedicine or the AI do benefit a very small and narrow section. So we need to be cognizant of that. And also, as Usha said, the data just doesn't disappear. It's not like you enter it into a computer and it disappears. It's being used in ways that sinister ways that we are not aware of. There's no information in the public domain about a lot of this. We are seeing, say, for example, you said about Elon Musk, Bill Gates has, bought, he's now literally the largest landowner in the US. And we don't know how all of these people, like here, he's the benevolent donor who's coming, he's talking about a whole lot of things. So, I think a lot of it we don't understand. Sometimes we work in silos. Yeah, I mean, anything else, Hamad, that we need to add? And yeah, also the Indian Journal of Medical Ethics has been, putting out a lot of articles on these issues. Like it's not exactly, just bioethics. It's the interface of health with a lot of other sectors. For instance, digital health, bioethics, like exactly what the conference is, focusing on. So if you have like articles or if you want to contribute perspectives, then please do. And also please subscribe to the IGME. I think it's one of the few journals that depends on people's contributions and subscriptions. And please read all the comments. I think there are a lot of very interesting comments. And I think if no one has anything more to say, then we should close it. Hamad, maybe a few last words from you and then we close it.
It was an absolutely great session. I really enjoyed all the presentations and talk. It was like the different lenses that we have to take being involved in healthcare. It has to be there. We can't take everything for granted, and these issues are real. We need to raise them at every forum that we can. And this is how policy is made when people discuss. Thank you.
Thank you very much, Hamad, Sylvia, Shrirupa, Usha, and Narendra. I think this was a fantastic session. And I know that I'm eating into the break a little bit, but just before we close, I wanted to bolster Sylvia's appeal. Sylvia, thank you very much for appealing on behalf of the IGME for seeking contributions from the people who are attending. But I've also posted in the chat a link seeking donations for the journal. IGME is one of the key organizers of this conference, and we are a platinum open access journal that is indexed in several all the important databases, and we are very critically thinking about how to make scholarship around medical humanities, medical ethics, bioethics, etc., accessible and equitable. And keeping that in mind, we've been trying to figure out what is the most sustainable way of going forward. And for us, it appears that going back to the community and seeking your help is what's going to keep us running. So I'm going to post that link again, and whatever you can contribute would be of great help in keeping the journal running in the form that it runs currently. Thank you very much. We'll come back at 6 o'clock, which is when the next session starts. Thank you. Thanks a lot to Shrirupa, Usha, Narendra, Sylvia, and Hamad once again for this fantastic session. Thank you.
Thank you.